Welcome once again to the Only You. I'm here in my home office, Dr. Tino in his office. Um, Appreciate all of your comments. We've been getting a lot of extra live interactions. We do appreciate that. And of course, please remember to click, share, and subscribe. Today, we're going to be speaking about something that I know I don't have a lot of knowledge about. I understand a little bit about mental illness, being with around Dr. Pino for many years. Understand the big names, right? Depression, bipolar disorder, ADHD, schizophrenia. But there's a subsection of mental health issues that seems very, at least for me, vague. And hopefully, doctor, you can shed some light on it for us. And that's something called personality disorders. What is that?
Okay. Let me tell you. Let me give you some background. Personality disorders has been a section of the statistical manual of mental disorders, been around for a long time, and is a constantly evolving process. Even though the whole issue of personality has been an area of psychology and psychiatry we've been involved with for a very long time. But I have to tell you, both for us psychiatrists, psychologists, therapists in general, is kind of like a difficult subject because there's a lot of excuse the term, there's a lot of subjectivity to it. So let me start by saying the personality disorders are not illnesses, right?
Oh,
So
okay.
we really have to get into understanding what is the difference between a disorder and a disease, right? So it's important for those people that have been labeled with having a personality disorder to understand that they're not diseased, right?
Hmm.
So how do we explain this in a way that people can understand? And the best way I have to explain, and I explain it to patients this way, is that personality disorders are situations in your development in which certain parts of your personality become more intense. And they also become frequent and predictable. Now, what makes things a little complicated is that in order to follow that train of thought, right, in terms of, okay, personality disorders are intensity, frequency, and they cause dysfunction, you have to have a baseline of normalcy, right? And one of the things that we have not been very good at defining in mental health in general is what is a normal personality,
Hmm.
right? So we have this situation in which we're getting pretty good at identifying those areas of the personality that are very intense, that they're frequent and predictable, and they cause dysfunction. But the absence of those doesn't make you normal, right? So we have to define the way I like to define normalcy is all of the abnormals in good balance, right? So when we talk about personality disorders, we're really talking about a subset of features of everybody's personality that are more intense, more predictable, and they cause more dysfunction, right? So one word that comes to mind in medicine in general is homeostasis.
Hmm.
Homeostasis means balance, right? So a good balanced personality is the closest we can get to a normal personality. So what who would be like that? Would somebody who can utilize certain aspects of the personality appropriately under the right circumstances, right? Because personality is that feature of our psychology that allow us to protect ourselves and relate to the rest of the world. So you have to be a little defensive sometimes. You have to be a little dependent sometimes. You have to be a little avoidant sometimes. Maybe you have to be a little obsessive sometimes. Maybe you have to be a little sensitive to rejection and criticism, or you have to be not needing people very much and be a little schizoid, right? So we start labeling those features into a disorder, but in reality, those are features we all have, right? Because if you're on the certain circumstances where you need to be sensitive, you be sensitive. You need to be avoidant, you're avoidant. You need to be dependent, you're dependent. So we kind of navigate life with some features in our personality that allow us to be human, if you may, right?
So, if you said that it creates this, obviously, anytime we have mental health issues, it's about how much dysfunction there is. If someone is cranky on occasion, that's just maybe situational. But if they're cranky all the time, does that really indicate a disorder? I mean, as long as it's not dysfunctional, could that just be their character?
Well, you see, we use the word character and personality interchangeably,
Okay.
right? And the question really becomes who defines dysfunction, right? You may say, "Hey, I'm cranky all the time, but it's not a problem for me." But maybe it's a problem for the people around you,
Mm,
and it creates problems in terms of relationships, for example, or it creates problems in terms of situations at work, or creates problems with excessive defensiveness or some paranoia, right? That everybody's against you. So again, under the right circumstances, you should be able to utilize certain features of your character or personality in a way that allows you to adapt, right? Now, here's what happens though. Personality is a fluid process of development, right? You're not born with a personality, you're born with a temperament. And
mm,
that where it gets a little more complicated. So you can say that somebody has always had the same temperament. Let me give you an example. When you're born, if you go to a nursery and there are 10 kids that were born that day, you line them up. Each one of them has a genetic temperamental imprint, right? Some are very tired all the time, sleeping all the time. Some are very cranky. Some are hungry all the time. One is crying all the time. The other one is fussy. So there's this feature that we're born with. Let's call that clay, right? So that's your biological temperament. Let's call it biological character and personality. That's temperament, right? So you go through development, from the time you're born until around you're 25 years old when we consider character or temperament completed, right? Biologically, psychologically, and socially. So life experiences, for example, how caring your parents were, attachment to your parents, communication with your parents, recognition from your parents, acceptance from your parents. And start molding that temperament, right, for adaptiveness as you get older. And then your universe expands and you go to school and you have more friends. And they also have a role on building that temperament and your experience, right? And then you go to the teenage years where things get hormonally more intense. You need to separate from your parents, so other changes happen to your personality, right? And then you get to your mid 20s, and you can say, "Well, I'm a grown up now." Nothing magical about being 18 and being an adult, right?
mm,
Biologically, psychologically, and socially, is around the mid 20s. So to some degree, people between 18 and 25 still have somewhat of an immature personality, and some of the features that you see like impulsivity, uh, poor decision making, things like that go together with that lack of development, right? But once you get to be in your mid 20s, there's an expectation that you're going to be better balanced. Those people that become predictable and intense and that causes problems around them or within themselves, then we call it a disorder, meaning that there's some symptoms that are intense that if you put them together, first create a syndrome, and then it becomes a disorder because there's certain features like longevity, like intensity, like predictability, right? So let's use an example. One of the most feared personality disorders among uh, therapists, for example, is people with borderline personality disorder. And that has become almost a bad word, right? And I
absolutely.
try to be very careful how we use those words because there's been a tendency to say if you have borderline personality disorder, nobody can help you, right? Only time will help. And that's kind of neglectful to some degree. So what is borderline personality disorder? Borderline personality disorder is an individual that tends to be chronically and consistently very intense. very intense in their emotions. They're extremely sensitive to criticism. They're extremely sensitive to rejection. They seem to have very long lasting feelings of loneliness and emptiness, very low self esteem, very poor self image. And they tend to be very reactive and impulsive, right? So they make decisions impulsively that can be detrimental to them. Now, most people consider them very intense people, very difficult to be with, right?
Mhm.
Because they're too intense. What we don't see though is what's behind what is in front of you, which is that these people are very lonely, they're very empty, and they're extremely vulnerable because they're extremely predictable, right?
Mhm.
So somebody with borderline personality disorder can be very easily taken advantage of. And because they're so needy for somebody to love them, right? When somebody gets close to them, they become extremely attached to that individual, but they feel so bad about themselves that they feel that relationship won't last. So they become very clingy, right? And the clinginess becomes a self-fulfilling prophecy. You become so clingy that that person don't want to be with you, and the message is, see, you're not worth anything, right? So it's a very circular process. And then they act quite impulsively, either in a self-injurious ways, like cutting themselves, or they become very injurious and impulsively using drugs, or impulsively getting into high-risk sexual behaviors, anything to feel that they have some sense of somebody caring for them. So you can see the intensity is so high, is so frequent, and is so predictable, right? That they keep repeating the same cycles over and over again. Right?
So how does
So
a
that's kind of an
professional
example of that.
So how does a professional like you who sees this thing make the distinction between the disorder and an actual illness? Because some of what you're saying reminds me of some of the other syndromes that you've spoken of, actual mental illnesses. What's the difference? Is one purely behavioral and the other one's chemical,
Well, there's a lot of
or do they
I
go
can
hand in hand?
well, is all of the above. I always like to say that any behavior has three components. It's got a biological component, a psychological component, and a social component. So what you have to look again when you're trying to diagnose somebody with a personality disorder is not a diagnosis you make lightly, and it's not a diagnosis you make without enough information. So what you want to do, whether it's borderline personality or narcissistic personality or cyclotimic type of personality or avoidant personality, is you have to look at the movie, right? You cannot make a diagnosis of personality disorder by taking a picture of the situation and come out with a diagnosis. So the movie of that patient's life becomes terribly important, not only in the context of childhood and development, but in the context of relationships with parents, relationships with other people, what you hear from other people. And something that I've noticed, let's get back to borderline personality in particular, the common denominator is not necessarily that these patients or these individuals have been abused, but most of them have been neglected, right? There is something about that clay, right? That when you have somebody who's temperamentally hot, right, from the time they're born, who gets significantly neglected, which every child craves the parents' attention, especially up until age 12, right? But once you get to that point, it becomes terribly important that you are giving attention to your kids because if they're temperamentally strong, they're going to demand your attention in angry, demanding ways. And if they get to adolescence without your attention and recognition and you being proud of them, they're going to start looking for that somewhere else, but they're going to become excessively and intensely attached to it, right? So neglect is very, very toxic for the personality development. And I mean, I don't want to say that abuse is not, it'd probably be number two. But in my experience for the last 34 years, neglect seems to be a consistent factor in terms of the development of intense, angry, and demanding personalities.
You've said many times that the vast majority of people who have mental health challenges never come to a psychiatrist or a psychologist. They're with their friends, their family, maybe they don't see anybody, or their GP. How would somebody listening who maybe thinks, hey, I'm a little, have some issues that he's mentioned, how does it do that? Is there a way for them to somewhat self-diagnose in order to at least take that next step to say, okay, I have a little more information, maybe I should go seek professional help for this?
Yeah, well, you see, we gotten so used to looking at symptoms that we have forgotten function, right? So I always like to tell people, listen, yes, I understand you feel depressed. I understand that you chronically get anxious or you chronically get angry, and that's creating conflict in your relationships. One question that I think people should be asking themselves is, what is this doing to my life? What is this preventing me from participating in life with, right? Because at the end of the day, it doesn't really matter as much what you have. I mean, it's scientifically and psychiatrically important for us to have a diagnosis and to know what's going on with the patient and to have a treatment plan. But at the end of the day, it's about the patient functioning better, right? One of the problems, though, is that a lot of people don't know what functioning better means, right?
Mm,
Because that's all they know. So we have a lot of people who believe that being in a Beverly abusive relationship is supposed to be
be
their
normal.
life. There's a lot of people who think that drinking a six pack every night is not a problem because they don't feel it's a problem, but they're not asking around, what am I missing by doing this? So it's, at the end of the day, everything we do in medicine and psychiatry should be directed not only at decreasing symptoms, but at improving the functionality of people. Now, don't take me wrong. I don't think that everybody should be happy. I think that happiness is a cherry on top, when things are going well. But I think that we all deserve to be content. So we need to change the parameters. We have bought into the idea that happiness is the goal. And I think we need to dial it down a little bit and say, no, I want to be content. I want to be able to function within my life and the people around me that I can give myself as a content human being, right? And I want to be able to explore contentment, not and have happy moments, right? I think that that's terribly important.
So, if in a way, then, so if somebody is thinking maybe they have one of these issues, really, it's not so much about how they feel. It's looking externally to see how have an issue. Someone's had multiple relationship breakups that are real tough ones, or can't keep a job, or any of the, or even has up and down and weight loss and very obviously external, I guess, variables that they can look at. That's really the biggest clue for them to possibly seek help.
Yes, you have to identify issues. I have to tell you that in psychiatry in particular, most of the people that come to see us, they don't come because they had this eureka realization that something is wrong and I need some help, right? It's usually precipitated by external events. Either I felt so bad that I decided that I wanted to end my life. I became excessively aggressive. I got a DUI. My wife wants to divorce me. My kids hate me. Things like that motivates you. So the external motivation seems to be the initial process, right? But I think that there's also something to be said about physicians becoming more comprehensive outside of psychiatry, you know, and and asking people not just how do I fix your fever or how do I fix your pain, but how do you want me to help you? That is a question that is very open ended because, especially in family medicine and internal medicine and geriatric medicine, you're going to be surprised by the answers you get, which is not fix me, right? It's just nothing, doctor. I just wanted somebody to listen to me.
Mm,
But we have kind of forgotten that the person in front of us is not an illness, is a human being that most of the time wants to be listened to and most of the time wants to be able to trust. And people that have intense emotions that have caused them pain in the past have a lot of difficulty trusting you with their emotions, right? So that's where the psychiatrists and the psychologists become useful on facilitating the process of trust. It's not that we have magic wands to fix people, because we don't, but we are trained to listen, and we are trained to understand. So at that point, it becomes easier for people to express their misery and their pain, because people feel very ashamed of it.
Mm.
Now, don't take me wrong, there are certain personalities that are very toxic, and toxic has been this is a word that has become very popular. The toxic wife, the toxic friend, the toxic girlfriend, the toxic doctor. And I think we need to stop using that word, because it's very demeaning, and it doesn't mean much. It just means a very intense person that I don't like, right? So, but there's certain personalities that are really, really pathological, that get closer to a disease, and those are uh, antisocial personality and narcissistic personality. You
And
know,
define those, because earlier you started kind of listing the different ones, and I've heard of a couple of them, but there was one in particular I think you mentioned. I don't it escapes you right now.
well,
And
antisocial
what are the most common ones that are out there, and what are the most dangerous?
well, antisocial personality is particularly difficult, because this is people that really don't have the ability to love. They don't have the ability to have compassion. They don't have the ability to understand. But they do lose control when they get caught in criminal activities.
Is that
So
not
these,
psychopathy?
no, that's sociopathy.
Okay, sociopath.
Psychopathy is not a term that we use very much, because you're really bordering between antisocial personality and psychosis, right? So
Okay.
that's the term sociopathy and psychopathy we don't use as much anymore. But antisocial personality will be closer to sociopathy.
Okay.
So these are people that tend to have,
Otherwise known as a
uh,
sociopath.
yeah, they really, yeah, they have a lot of difficulty with respecting the rules. They get into criminal behaviors, impulsive behaviors. They have no remorse for any of the activities they get themselves involved, but they do get very angry when they get caught and confronted, right? That is very pathological. That's significantly overrepresenting among criminal people. And then we have narcissistic personality. That is, it's an interesting variation uh, of borderline personality, but it is someone who is very self-centered, again, with very little compassion or remorse. They're very conning in terms of utilizing other people, right? And it's all about them. It's about my gratification. Now, the problem with narcissistic personality is that they're very manipulative, and they can come because they have this significant need for admiration. They try very hard to show themselves as being great,
Mm.
right? So it's very easy to be attracted to someone with narcissistic personality. Now, the reason though that narcissists tend to show a lot of false caring and grandiosity, and they're very good at everything, and they succeed at everything, and they're kind of perfectionistic. So it's easy to idolize them, right? Is that underneath they're terribly insecure. So they need your admiration, right? So they can feel that they're worth something. So they're borrowing your self esteem from you, right?
Mm.
The problem is that when you start saying, well, I don't like this, and you start removing yourself, they become very angry, and they become easily aggressive, and they can be quite abusive, right? And then they're very good at making the other person responsible for what they feel. So how dare you do this to me? That will be an easy way to understand the process. Don't you know who I am,
Mm.
right? And these people can be potentially dangerous, because if you suddenly leave them, it's like if you take their self-esteem with you, right? So they're quite retaliatory. It is important to be able to recognize when you are in a relationship like that, and recognize that a very, very basic principle in psychiatry and psychology is that we are not responsible for anybody else's feelings but our own, right? So we have to first be well with ourselves, but when we have a need to satisfy other people's emotional needs, we have a problem.
Mm.
right? So that requires, usually in those situations, we end up seeing the victim of the narcissist first. And very seldom we see the narcissist because, of course, from their perspective, they don't have a problem.
Wow. So, in addition to those other two, what are the most common personality disorders?
I think that the most common ones will be uh, in the anxious people avoidance, right? People that tend to be wanting to be part of an environment and society, but the anxiety is so high that they prefer not to do it. So they restrict themselves, but they're not happy with not being able to take those risks. And not unusually, people with avoidant personality tend to have kind of isolated, normal lives, but they don't have a lot of friends. And that's different than schizoid personality, which is people who don't need people.
Mm.
They're very content with not having people around, right? We have so probably avoidant dependent will be a combination that we see frequently. People that have somewhat of a need to have somebody who supports them, okay, and they're there for them. Uh, but we see all kinds of variations. So the pure personality disorder, quote unquote, is rare. We usually see more mixtures, right?
So, if somebody feels that they know somebody that is having this, or even they become a little self-aware after listening to this and said, "Hmm, that sounds a bit like me," what are the steps to get help?
I think that most of the people will go to get help because they get depressed or get anxious. Okay. And as they're starting therapy, as they're seeing a therapist or a psychologist, or they start taking some medications, they notice that the symptoms of depression and anxiety decrease, but their interactiveness continues to be somewhat problematic. So I do suggest that most people start seeing a therapist or a counselor. I do suggest that the counselors look at the possibility that some of these are personality traits or personality intensities, and to try to provide the patients with some guidance into the how to. You see, traditional therapies are very focused on why, right? Why do I have this? Okay, and those that question is rarely answered. I mean, you have somebody with classic severe trauma, you can say, well, there's a connection between the trauma and your behavior and your flashbacks, and maybe you have PTSD, right? But in general, it's very difficult to pinpoint one reason why people are depressed or anxious or intense, right? But I think it's easy to identify the dysfunction and for people to ask the question from the therapist. Now, I always tell my patients, don't ask the therapist, why am I feeling this way? Ask the therapist, how do I go about it?
Hmm.
How can I learn some skills so I can cope with it differently? Because what happens with, remember what I said before, people with intense reactions and dysfunction are predictable. So they always react the same way. And when you always react the same way, people learn to know your reactions. They also learn to push your buttons, right? So if you can learn new skills, you can start practicing new skills so you can take more risks, right? So you can get, we talked about this before, you can get out of the bubble of misery
Hmm.
that we frequently talk about, because the bubble of misery on somebody with a serious personality problem becomes very safe, right? And especially, for example, in borderline personality disorder, people just get out of the bubble in very impulsive, angry, destructive ways and then goes back to the bubble, right? So can the therapist extend a hand with empathy and compassion, understanding that what you're treating is an individual who's suffering and not a disorder, right? Not an illness.
So
That is
once
the
again,
intensity we're looking at.
like you've said this many times, we don't cure anything. We really just help the functionality of a human being. So it's not so much of a person with one of these disorders saying, "Take this away from me." It's more to show them how to live a more healthy, more functional life with that disorder that they do have.
But you see, and I had to remind you of the words from my father, who's deceased now, but, and this is a very humbling idea that it takes our us physicians very long time to learn. We very seldom cure anything. All right. I mean, if we can kill it with an antibiotic or remove it by surgery, then we maybe cure something. But outside of that, we just help people live their lives in less intense, with less pain, and less dysfunctional ways. But half of that job is not the physician's job, it's the patient's job.
So the
Hence the
partnership
only you,
between the
right?
two. Absolutely. So the partnership between the physician and, of course, the patient or the person seeking some solace. Once again, doctor, appreciate your information. We've stayed somewhat within our time frame. A fascinating topic. I know I want to hear more about the individual specific ones and how those things go. Everybody out there, much appreciate your time. Please remember to like, subscribe, and share. Any last words, doctor?
Oh, just to remind everybody that we're here. We're going to continue talking about personalities. Maybe down the road, we'll do more specific personality. I'm actually doing a presentation for therapists this week. On February 10th, talking about specifically borderline personality disorder, an area that I've been very interested with, and dissociative disorder. So, thank you very much again. We'll see you next week, 5:30. Thank you,
Take
Vince.
care. Have a good one.
Take care.